This slide, I think, is from something called Creating a Healthier Future. Some of you may remember, must be from at least 10 years ago. A whole thing about preventing errors in the NHS and how can we limit the incidence, in this case of GBS, and how can we create systems that will tolerate errors, and how can we affect, if you like, human behaviour to prevent this. Now, any talk you go to on risk management will have this famous slice of cheese on it, which you've all seen. And I was struck by the honesty of some of the previous speakers in some of the inefficiencies, errors, and omissions. So we've all got guidelines. We all think they're being adhered to. When something goes wrong, we're sort of surprised that the guideline wasn't followed, or there was some change in the guideline. And I must say that I've got to the stage in my career that every time there's an adverse event and we have to review it, there's no question about it, the communication, either within the teams or between teams, is a very common theme when it comes to adverse events. And certainly having a baby with Group B strep is for sure an adverse event. One of the things I wanted to raise, and this probably will echo with the neonatologists in the room, is every day we have a handover, and as part of that handover the trainees talk about, inverted commas, well babies on the postnatal ward. Maybe they're not feeding well, they've been a bit jittery, there's some jaundice. Now, without a shadow of a doubt, they will preface, the first thing they say is, there are no risk factors for sepsis. I hear this every day, 7 days a week. And sometimes I'm sitting there and I'm thinking, how do you know that? How do you know there's no risk factors for sepsis? We all know if you remember the Donald Rumsden thing, the things we know and we don't know, there's all these babies in the postnatal ward, there's lots of stuff that we don't know. But every day I hear this, there's no risk factors for sepsis. Okay, so that's one of the problems. I mentioned handover. We're all very busy. We know there's lots of staffing shortages. You're all working in shifts with multiple shifts, multiple handovers, with multiple opportunities for information to get lost. And I just think we need to step back from the data into the day job and what actually happens. And guidelines have been mentioned. My other hat is as a foundation training program director. Now, the foundation doctors, that's housemen in the old money, they have to deal in our hospital with about 80 admissions a night. Patients in their late 80s with multiple comorbidities. To survive the shift, they need to have, I think it's either 70, that's 70, or 90 guidelines to survive one shift. We've talked about one guideline. Every single one of you in your units has got dozens of guidelines, probably 3 figures. I suspect if you went to work, if you just suspend your disbelief for a moment, and there was only one guideline you had to follow, and it was Group B strep, you'd probably be quite good at it. But it isn't. We haven't mentioned the guidelines for postpartum hemorrhage, for induction of labour, and so on and so on and so on and so on. And these are things that you're all expected to remember, to have access to adhere to when you've got bank staff, agency staff, doctors rotating every 6 months, etc. So I do worry about the guidelines as the solution, and I do respect the honesty of the audits from the obstetricians showing that implementation is a problem, the variation between units and within units. And Professor Steer, that's the same slide, won't show that, mentioned the word inefficient. He said that, I hope I'm quoting you right, Professor Steer, you said that the risk-based approach is inefficient. And this is a slide that I took, I'm going to be honest, this is our hospital many years ago, and this is an example of why it's inefficient. So I took a photograph of a woman's notes. Not sure if I dare touch the pointer. But somebody was very concerned because this woman had Group B strep in the urine, so they wanted that to be known. They wanted something to be done about it. So they thought, and some of you have heard me speak, I've shown the slide many times before. So they thought, they'll write in the notes that there's Group B strep in the urine, but I'm going to write it in big capital letters. And just to be on the safe side, I'm going to put an asterisk on either side. But then to make really sure, I'm going to get a yellow highlighter pen and I'm going to underline it. And that way everyone's going to know this woman's got groupie strep. And just as an absolute extra safety, I'm going to get a different coloured highlighter and put that under. Now you will not be surprised to hear that this woman did not get her IAP, and the baby presented with seizures, was on our neonatal unit, had an abnormal MRI scan, which I'm not going to show, and at the age of 2 was deemed to be normal. Now we heard speakers this morning. I will put my hand up and concede we did not follow this little girl up to school age. I have no clue how she's doing at school. So I use the word normal with inverted commas. And this is a reality of the current system. So I'm just trying to throw that into the mix, that there's all sorts of human factors. We think we got these guidelines. We've already seen from earlier presentations, the introduction didn't reduce the rate, that there's problems with adherence. And I would much prefer to have a system. I mean, I was thinking this morning on the tube on the way in, I don't actually remember the last time a baby didn't get a Guthrie screen done. It just happens. The magic fairy does it. It just seems to happen. And ditto ROP screening. I should imagine it's quite difficult to be pregnant and not get your serology done. It just happens. And I'm sort of thinking, wouldn't that be a good idea for GBS? Just becomes part of the routine. Anyway, that's just my personal view. As I said, no data, no pictures. But I just wanted to flag up the human factors about why we're not quite as good at doing this stuff as we think we might be. Okay.